Good afternoon. I'm Tareerat Chemnasiri. Today, Dr. Sarika and I are going to present the novel approaches to improve adherence, persistence of PrEP programs in adolescents. This presentation will show you our two studies. The first part that I'm going to present is the lessons learned from our completed HIV prevention study, COPE, or Combination HIV Prevention Effectiveness for Young Thai MSM. And Dr. Sarika is going to present the result of the Young Men Who Have Sex with Men cohort study and the PrEP provision sub-study. This is the PrEP timeline in Thailand. From the past 10 years, Thailand has progressed from one of the research sites in the IPREC study to offering free of charge PrEP services under the Universal Health Coverage, or the UHC. In 2021, 5,000 PrEP users were targeted by the UHC. Let's start with COPE study. COPE has two study phases. Phase 1, qualitative assessment and community engagement, and Phase 2, combination prevention effectiveness study, which combine effectiveness and cost effectiveness of the study. The purpose of the COPE study is to develop and assess the effectiveness and cost effectiveness of a combination intervention for prevention of HIV infection among HIV uninfected at-risk young men who have sex with men and transgender women in Bangkok and Pattaya, Thailand. Phase 1, qualitative assessment and community engagement. We conducted 86 key informant interviews between July 2016 to July 2018 with 62 young men who have sex with men and transgender women with a history of traded sex with men and transgender women for the last 12 months, and 24 staff and management of sex work venues. We purposefully recruited them through community-based organizations that work with MSM and TGW who sell sex and sex venues. The study settings are Rainbow Sky Association of Thailand, or ASAT, Service Workers in Group Foundation, or SWING, and Siloam Community Clinic at TropMed, or SCC at TropMed. For data collection, we use a short questionnaire to collect social demographic and behavioral data. During the interview, we use semi-structured interview, that is the interview guides, to collect qualitative data such as sexual decision-making, HIV prevention knowledge and practice, health-seeking behavior, PrEP knowledge, feasibility and acceptability for participation in an HIV and PrEP study. The key informant interviews were audio recorded, transcribed, and analyzed using Atlas TI qualitative data analysis software. After qualitative data analysis, we analyzed the insights of community experience with PrEP and sex work. These interviews showed us that at that time period, PrEP was not very well known. But after we described about what it was, how to use it, what benefits they would get from PrEP, then we understood that PrEP is needed and wanted by the community. We learned about the diversity and range of sex work among young MSM and TGW in Thailand, which helped us better understand our target population and how to best serve them. The interview data provided valuable input on study design that we incorporated into the effectiveness and cost effectiveness phase, or study phase 2. For phase 2, effectiveness and cost effectiveness, the study was an open-label, non-randomized assessment comparing the relative effectiveness of a combination preventive intervention with and without daily oral PrEP with adherence support. As shown on the slide, we offer 6 main components or combination HIV preventive intervention, which were regular HIV testing, HIV risk reduction counseling, condom and lubricant distribution, STI screening and treatment, community engagement and mobilization intervention, and daily PrEP with SMS reminder support. The outcome was assessed using a person-time approach, assessing HIV incidence densities among young MSM and TGW on and off daily oral PrEP over 12 to 24 months of follow-up. These are the list of inclusion criteria. The participants were HIV uninfected, Thai, born male, young MSM and TGW age 18 to 26 living in Bangkok and Pattaya, Thailand, who were willing to provide contact and locator information, willing to give informed consent, and self-report having sold or traded sex to a man for money, drugs, goods, or services in the previous 12 months. For study recruitment, we found that using social media influencers as community engagement are effective. With the support from APCOM, the group of experts in the field of promoting HIV campaigns, we launched the promotion during September to December 2018 and August 2019, using 3 promotional channels, 10 online platforms, and 3 types of media. The impact of social media campaign increased weekly recruitment rate by 2.1 folds, comparing to the traditional outreach that recruited around 4 participants per week. Among participants enrolled in the study, 33% self-reported learning about the study through the social media. However, social media should be utilized together with the traditional outreach, both online and offline, for the comprehension recruitment strategy. The enrollment period of this study was October 2017 to August 2019. 1,312 potential participants were assessed for eligibility. 921 potential participants were found to be eligible. 890 participants were enrolled into the study. 44 participants withdrew from the study due to HIV infection at baseline. Overall, 846 participants were offered PrEP in the COPE study. This slide shows the participant characteristics at baseline. A majority of participants reported their age between 21 to 23 years old. Almost 90% reported their gender identity as men, gay, and bisexual. 9% reported as women or TGW, and 2% as other or do not know. Most participants reported completed bachelor degree education. For PrEP, 85% reported that they heard of PrEP, and 76% were willing to take PrEP every day. COPE study screening and enrollment. SCC at TropMed started the enrollment in 2017. In 2018, RSAT and Swing Bangkok started the enrollment, and Swing Pattaya started the enrollment in 2019. From the total of 846 participants enrolled, 480 at SCC, 207 at RSAT, 133 at Swing Bangkok, and 26 at Swing Pattaya. 63% of total participants started PrEP at the enrollment visit, 12% delayed their PrEP initiation, and 25% refused to take PrEP during the study, and 5% found HIV positive at baseline. After the participants started PrEP, did the participants take PrEP as prescribed? Good PrEP adherence means the participant take PrEP at least 4 doses in the past 7 days. But for the participants who are using feminizing hormones, the one who are using the hormones, good PrEP adherence means PrEP must be taken 7 doses in the past 7 days. So we found that 94% good adherence overall, which are analyzed from the self-reported adherence. The participants self-reported their PrEP adherence through 2 channels. weekly SMS survey, and how they talk with the nurses and the counselors. After study follow-up period completed, we collected 885 person years, which are 593 on PrEP person years and 292 of PrEP person years. During the study, we quarterly found 93 to 96% retention, and we collected dry blood spots on every visit to compare the data between self-reported adherence, leftover pill count, and TDF level for reliability. Now we are looking at PrEP use over 12 months among 574 participants starting PrEP within 30 days of study enrollment. This slide is the percentage using PrEP at the follow-ups among participants starting PrEP within 30 days of baseline and who are still in the study at that follow-up. This graph presents patterns of PrEP use and HIV testing among 10 COPE study participants with HIV seroconversion. There were 10 seroconversions during the study. The dark blue bars are time on PrEP, and the light blue bars are time off PrEP. The green lines are HIV negative test results, and the red lines show the day HIV are diagnosed. Looking at all red lines, none were taking PrEP when diagnosed with HIV. From 10 participants, numbers 6 to 10, 5 participants never received PrEP, and number 1 to 5, another 5 received PrEP at baseline and at the time of their last negative HIV test. So what we have achieved here? We successfully developed and implemented a combination prevention package with Truvada, which achieved high adherence and high persistence in a cohort of young men who sell or exchange sex in Bangkok and Pattaya. We established high community demand and preference for Truvada for PrEP. We found high PrEP adherence rates with dry blood spot via TDF testing. And we found that social dynamic use and technologic use among young and vulnerable communities can be used to augment outreach method. So thank you for your attention, and welcome Dr. Sarika for the young MSM cohort study and the PrEP prevention sub-study. Thank you.